You're listening to Medscape's In Discussion series on Cardiorenal Metabolic Syndrome, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Nihar Desai. Dr. Desai is an associate professor of medicine and vice chief of the section of cardiovascular medicine at Yale University School of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Nihar Desai from the Yale School of Medicine. Welcome to Season 1 of the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast series. Today, we're discussing implementation science in the context of cardiorenal metabolic syndrome. I'd like to welcome our expert guests, two close friends and colleagues, Drs Tariq Ahmad and Ankeet Bhatt. Dr. Ahmad is an associate professor of medicine and chief of the heart failure program at the Yale School of Medicine in New Haven, Connecticut. And Dr. Bhatt currently serves as associate physician at the Kaiser San Francisco Medical Center, a research scientist in the sections of cardiovascular and metabolic conditions and healthcare delivery and policy at the Kaiser Division of Research, and on the faculty in the Department of Health System Science at the Kaiser Permanente Bernard J. Tyson School of Medicine. Welcome, Tariq and Ankeet. Thanks so much for being with us today.
Nihar, thanks for having us.
Nihar, it's a great honor to be here and good to have this discussion with friends and colleagues.
Well, great. I couldn't be more excited to have this discussion with both of you. I know this is a topic that we are very passionate about: implementation science. How do we make progress? How do we deliver on everything that the healthcare system needs to deliver on for our patients and the communities that we serve? In this podcast series, we've obviously had a very wide-ranging discussion, so I'll just highlight for the audience to please check out all the other topics as well, but you'll hear things from the AHA presidential statement on cardio-kidney metabolic health, a discussion on epidemiology, social determinants of health, a very comprehensive review of evidence-based and emerging novel therapies to manage cardiorenal metabolic syndrome. But in many ways, our topic today, implementation science, is sort of the linchpin. If we don't get this part of the story right, if we aren't able to actually bring all of these therapies to the patients that need and deserve them, then I'm fearful that most of the other discussions are for naught and become moot. And so with that, we're very lucky. We have two experts in the field to really help us walk through this. And so maybe we'll start off just with, what is implementation science? What does it seek to study and accomplish? And maybe Ankeet, we'll kind of start with you with just kind of a definition so that all of us are on the same page.
Broadly speaking, it's the scientific study of methods and strategies that facilitate the uptake of both evidence-based practice and research into regular use by practitioners, by care providers, and by policymakers. More simply put, it's strategies that help to close the gap between what we know and what we do. As you alluded to, I think it really is this final common pathway. It's the body of research that's most closely to that of clinical care because it intersects with clinical care innately. The area in which we can take all of the scientific discoveries and all the work that's been put in to developing those discoveries and bring them to patients at scale.
Tariq, maybe sort of have you give some introductory comments, and maybe from your perspective, how do you think about implementation science? What is it? What's the work that we're going to spend the rest of our program today talking about?
Well, thanks, Nihar. So Ankeet put it quite brilliantly, but from my perspective, I see this time as the golden era of biomedical research. We have therapies now that humankind could never even have dreamt of. I mean, we have treatments that are highly effective, that save lives, that keep people out of the hospital. There's been a dramatic growth in those therapies over the last 20 years. Just when, Nihar and I were training together as house staff not too long ago, we had only a fraction of these therapies for heart failure, for example. Now we have these riches of therapies, but it really does not make much of a difference to the individual patient unless they get those therapies. And that's what's driven me And that's what implementation science means to me. How do we get those therapies that are life-saving to the patients who need them? And what's guided us has been the dramatic difference between the science and the usage of these therapies at the bedside. And for me, implementation science are all the different things we can do to bridge this fairly large gap in heart failure.
Yeah, I really appreciate the way, both of you kind of laid this out. And it is important for, I think, all of us to understand, and certainly for the audience to appreciate that implementation science is a deep science. There's a rigor, there's a set of methods and a set of frameworks and principles. But I also think that, both of you also, I think rightfully focused on, it's exquisitely focused on what are we actually doing for the patients that we serve? How are we going to fill this very conspicuous gap between evidence and practice? We have all of these therapies, we have all of these guidelines, we have all of this literature, and yet what happens in routine clinical care is something that's very, very different oftentimes from what that evidence would suggest we do or what those guidelines suggest we do. And I think implementation science in that way really says, hey, let's figure out what works. How do we fill these care gaps? And how do we spread and scale those to other places so that all patients and all communities can benefit? Let's very quickly highlight some of the key care gaps in the cardiovascular, renal, and metabolic syndrome space. And I want to sort of focus maybe on two elements of this specifically. One aspect is underdiagnosis. And so where are we in terms of basic routine understanding to guide which patients are at risk or already have CRM syndrome, specifically maybe the use case or the example of urine albumin to creatinine ratio testing. And I think all the under evaluation of that very important element of this clinical syndrome. And then we'll sort of switch gears and talk about underuse of evidence-based therapies, whether that's SGLT2 inhibitors, GLP-1s, or other therapies. There's so many, sadly, so many examples of that. But maybe we'll sort of touch quickly on both of those. And maybe I'll turn to Ankeet again about what do we know about underuse or under testing of UACR as one kind of prime example of the evidence practice gap that we're trying to fill.
Thanks, Nihar. As you and Tariq really, I think, elegantly put, the fun and what makes implementation science, I think, such an exciting field for research is that it follows the patient and provider journey. Zooming out, there are implementation science initiatives aimed at diagnosing conditions. You talked about one, which is UACR and proteinuria testing in patients with kidney disease. Another example of that would be the recognition of certain forms of heart failure, for example, heart failure with preserved ejection fraction. So there's a diagnosis piece where implementation science can play a role. There's an area in which we can learn how to implement effective therapies across the CRM spectrum. That is a really exciting area because the number of therapies has grown, as Tariq has alluded to, but also there are particular therapies that are at the nexus of these CRM comorbidities and are effective across multiple domains of that. The way I view it, there's sort of a final pathway, which is once you have patients on effective therapies, they need to stay on them to get the population benefit that these therapies would otherwise provide. And so there's a whole piece around implementation science that promotes adherence and promotes equity in both the initial prescription and the adherence to those medications. So that's sort of the broad framework in which I think about this. Specifically, UACR testing, I think, is a really nice case example of the first pillar that I sort of discussed, which was around underdiagnosis. We know that chronic kidney disease affects a large percent of the population, but in many cases, we've defaulted to a measure of glomerular filtration rate as an indicator that someone has chronic kidney disease. What we know from the epidemiology is that proteinuria, irrespective of a patient's creatinine or eGFR, can be an important prognostic marker for the progression of kidney disease. However, we're not testing for this in routine clinical practice in a way that mirrors that of our guidelines. So it's an important area of further study. So maybe I'll kind of pause there and see if you and Tariq have any thoughts around that.
I think that's a really great framework that you put forward for us. And then I couldn't agree with you more on sort of the UACR front. I think we continue to see under testing of something as simple as a urine albumin creatinine ratio that can be done by every healthcare provider and bring so much complementary adjunctive information in terms of profiling patients with CRM syndrome. And yet we see time and again that rates are less than 1 in 5 or maybe even 1 in 4 patients who actually get and receive what the guidelines recommend in terms of testing of UACR. Maybe I'll have Tariq then comment on the other side that we kind of raised around this underuse of CRM therapies. And again, not getting into a in-depth discussion, but I thought, Tariq, is there some data or something that you might share with the audience about just how big of a problem is underuse of CRM therapies?
I would say that this is one of the greatest challenges facing American medicine right now. I think every clinician and patient would tell you that the best thing to do is to prevent disease. We see a lot of patients in the hospital with heart failure, end-stage kidney disease, who need dialysis, who need transplant. And it's, one aspect of our practice, but the most important thing I would argue that we do is to prevent those outcomes, to prevent patients from progressing to end stage of any disease. And for the first time in history, we have therapies that we know will prevent the progression to advanced disease. The most important thing then becomes being able to diagnose patients at an earlier stage of disease. We have biomarkers like the one that you mentioned before for kidney disease. We have one for heart failure. I routinely check natriuretic peptide levels to pick up patients who have earlier stages of heart failure. And we know that once we can diagnose early stage heart failure, as a case example that you brought up, then we can use guideline-directed medical therapy to dramatically reduce their progression in disease. And unfortunately, both the diagnosis of heart failure and the use of guideline-directed medical therapy is incredibly low. We know from national registries that only a small percentage of patients are on appropriate doses of the 4 pillars of guideline-directed medical therapy: beta blockers, ARNI, MRA, SGLT2 inhibitor. And unfortunately, this has major population health negative impacts because these are the patients who end up getting hospitalized for heart failure, who have progression in their disease to a point where the medication stopped working. With these new therapies that we have, most of which were not available 20 years back, we can really start to think about preventing heart failure, preventing end-stage renal disease, and that's obviously starts with appropriate diagnosis.
It's a pretty sobering statistic, right? When we look at the proportion of patients who might be candidates or eligible for some of these therapies, and then you sort of stack that up against the proportion that actually are receiving them. Are there some numbers or things that either of you might want to share around that front of just kind of how big is this evidence and practice gap? And maybe not just overall, but have we learned anything or do we know anything in terms of race, ethnicity, or socioeconomics or social determinants of health that might also underlie some of the disparities in the use of these therapies? Any comments that either of you want to make on that front?
Sure. What I find troubling, but maybe highlights where implementation science can play a important role, is that we know for each of these conditions, there's large evidence gaps. If we take heart failure, for example, we know that, less than 5%, some registers say less than 1% are on multi-drug, disease-modifying, guideline-directed medical therapy at appropriate doses. What we also know is that as patients gain CRM comorbidities, the likelihood that they're on these effective therapies actually goes down. So there's this paradox between being at higher clinical risk and having less implementation of disease modifying therapies. And so, it's really troublesome because these are the people that are going to progress, as Tariq said, to end stage forms of CRM conditions, whether that's heart failure, kidney disease, or otherwise. But we're actually treating them the least aggressively. And then you compound that on the socioeconomic and sociodemographic inequities that we see in implementation of guideline directed medical therapy, where the most disadvantaged groups are the ones who are potentially have the most to gain from these therapies, but are receiving them with the least prevalence. That intersection is quite concerning for our field, in which both there's a risk-based paradox with getting guideline-directed medical therapy and also a socioeconomic paradox with the patients that need it most potentially having the least uptake of those therapies.
Yeah, really critical points. I think you made so many of them there. I think we've kind of teed up the discussion and the importance of this notion of implementation science, I think, really well.
And here, the other one additional thing that I wanted to add was that there appears to be this interesting behavior as well amongst clinicians where there is a long delay in starting newer therapies. So, beta blocker uptake is good. ARNI uptake took several years. And then MRA and SGLT2, as you might imagine, people are quite slow in adopting. And there is this concerning learning that we're getting from implementation science that a lot of this is from therapeutic inertia. So there is clear evidence that we could do a lot better with usage of these medication. The other thing is, on a patient level, it is quite dramatic when you see patients in clinic and you add these therapies and you can watch both the heart function and the biomarkers get better. And I think that's something that we need to drive home, because if you can start see these illnesses as things that we can treat and reverse the course of, that message really needs to kind of get back to individual clinicians who may not completely understand the major, the massive impact on these therapies in modifying disease.
Yeah, it's such a great point. I'm so appreciative that you kind of raised that. And as we think about where do we go from here, how are we going to make progress? It seems like such a huge challenge, a monumental challenge before us. Maybe I'll get both of you guys to share, what are some of the key barriers that are impeding progress? Why is there this evidence practice gap? I know, Tariq, you already started some discussion, this notion of sort of clinical inertia and what goes on in the exam room or in the hospital. So maybe, Tariq, I'll have you continue on this notion of clinical inertia, but then, what are some of the other barriers that you think are really important for us to tackle?
First of all, there is clinical inertia because you're seeing that patient in follow-up. It's a 20-minute visit. It's a lot of work to add an additional medication. That certainly can disincentivize clinicians from doing that extra legwork. The other thing, and this is very important for patients, is cost, which you've written very key landmark papers about. We need to make sure that we're able to tackle the financial toxicity of certain things. And we certainly work very closely with patients to get them on the right therapies. It's also informational. So we'll get into this later, but we've designed interventions that use the electronic health record to get beyond informational gaps that individual clinicians might have and nudge them to get people on the right therapies. And then, as anything, it's health system incentives. So if the entire health system is aligned that this aspect of quality is very important, then they can put a lot of resources both on the macro and the micro level to get their patient population on the right therapies.
I think Tariq put that really nicely about the facets and the barriers to implementation across the way health systems and care delivery currently operates. I do agree that there is clinical inertia at the nexus of the provider-patient interaction. Our visits are infrequent, they're brief, they're filled with lots of things to talk about, and it becomes very challenging to both start a new therapy, educate a patient on new therapy, and promote adherence all within the context of a short visit. where that takes us is that systems need to start thinking about this more holistically and rather than just at the patient provider level. So thinking about population health initiatives, and if the ethos of a healthcare delivery system is that we should be studying these strategies in the context of quality improvement, in the context of just the way we deliver care, as Tariq, I think, nicely put, then there's incentive both in terms of effort and financially to be able to study these strategies at scale, to keep the ones that work and integrate them into usual care very, very quickly, and to not implement the strategies that don't seem to be effective. That's going to take a redesign from a healthcare system perspective. But I think it's really where we need to go, because this is the right thing to do for patients, and it translates all of the discovery and the upfront cost and time that researchers, that clinical trial participants, that others have put into developing and bringing these therapies to the market, and takes that last mile towards implementation.
I now really want to get into kind of the final piece of our discussion today, which is, what are you most excited about? What's happening in terms of implementation science? We've identified the barriers. What are the solutions? What can our listeners, kind of take from what are institutions and groups doing to try and solve some of these problems? And what might they also engage in? What are some of the things and tactics and tools that they might be able to leverage to make progress within their own kind of local environment? And so is it the EHR? And I know Tariq already raised that. We've done some work in that space. I know Ankeet's also been very active in that space, also with digital technologies. Is this where we're going to rely on, novel tools and remote monitoring and other kinds of devices? And I think both of you rightfully talked about some of the incentives and maybe some of the perverse incentives that we have in our current predominantly fee-for-service volume-based payment system. But do we need a new model for care delivery, a new model for maybe how we finance healthcare? Those are obviously very large policy level changes, but I'm sort of curious to get both of your perspectives on what's out there that you're excited about, because we got to solve some of these challenges and barriers. So maybe, again, we'll kind of start with Tariq and then go to Ankeet.
This is such an important question. And the great thing about the space right now is that there's so many brilliant people that are starting to think about this. When you and I were kind of training, we focused a lot on clinical trials, but then we would see clinically that there was less of an uptake at the bedside. And now we're kind of focusing on implementation. So I'm super excited about, everyone's kind of coming together and thinking about this in terms of how do we get these therapies to the patients in the most efficient way possible, the way, for example, we do with flu vaccines at CVS. So I think the most easy step, for example, would be, and I'm very biased here, but to use the prompt HF intervention that we tested at Yale at other healthcare systems, and we've already been doing that. I mean, we get contacted once a week from different healthcare systems to integrate the alert in their healthcare system. And we're already live at Inova in Colorado and Columbia, several healthcare systems. But I think that there's still a gap that would require other interventions. I think, integrating wearable technology and remote monitoring to be able to get these therapies to patients without them needing to come in for clinic visits. So doing as much of it remotely as possible would be important. And in the future, the question is, do we move away from the current kind of care delivery setup where we require kind of patients to come into clinic to get their care, to having some of chronic care management being done at other sites? I think that will have to be in the discussion as we start moving from, as you alluded to, fee-for-service to more quality of care. And it's only a matter of time, because I don't think that the healthcare system can sustain the current approach.
Yeah, Ankeet, I'd love to get your thoughts. And again, it is so exciting. And I will fully endorse, everything that Tariq has said. There's so many technologies, there's so many solutions. And is it the EHR? Is it something that's freestanding? Is it, something else that's a patient engagement tool? That there's so many things that are happening there. How are we going to actually know what's working, and then how are we going to scale it? So if we really want to solve these challenges, I'd love to get your thoughts on, what are you most excited about? What are you working on? But then also, how are we going to make sure that we scale up and actually make progress?
Thanks, Nihar. I share your and Tariq's excitement. I think it's a great time to be an implementation science researcher. The field's totally wide open. The gaps are pervasive. The therapies are abundant. I'm not, there are many things that I'm excited about in the implementation science field and strategies. I guess what, more broadly speaking, I'm actually very excited about building a platform for what I'll call precision implementation, meaning that one strategy is not going to be the end all and be all for a system. The gaps are too large and the therapies are too complex. Where I do think we can start is making the easy things, sort of implementing the easy things. You and Tariq have really led much of the seminal work on taking an existing tool, the electronic health record, and using it to improve care. You've shown that now in many respects. And I think the broad scale sort of adoption of successful tools in that space is an easy win. And then there's sort of the more broad scale initiatives like the ones that use digital technology. We've seen an explosion in the availability of technology and capital, which has brought a lot of sort of health tech platforms to the market. And I still think there needs to be a clearinghouse here because there's so many tools. Most of them have had little validation and little rigorous validation across health systems. I know, Nihar, you've been integrally involved in some of the initiatives to develop high quality evidence there. For those tools, finally, I do think that there needs to be an alignment between performance on implementation science initiatives, for example, looking at a provider or patient level to understand how providers prescribe evidence-based therapies, and then tailoring implementation initiatives based on performance.
Well, thanks so much. I really can't say how grateful I am to have had both of you join our discussion today and really cap this podcast series. We said at the top that implementation, and especially in this area of cardiorenal metabolic syndrome, is really the linchpin, that all the things that we have and all the therapies and all the tools to really have impact at an individual, at a community level, at the population level, there's such an immense opportunity for us. And yet, if we don't do the implementation part of this and we don't get that part of it right, I'm afraid what will happen to the health of our country and those that we serve. And so I think this has been a terrific discussion. I think what you laid out for the audience is both the compelling need for this kind of work, what excites you, what are some of the barriers, and just the importance of making sure that we are focused on this. And so I want to thank both of you again for taking some time out of your schedules to join us for this. And so Tariq and Ankeet, my deep appreciation to both of you.
Nihar, thanks for the invitation. This was a lot of fun.
This was great, and I hope we can impact all those patients out there. I think it's really exciting.
Thanks again. And I'll just say for our audience, please take a moment to download the Medscape app to listen and subscribe to this podcast series. Thank you again for joining us. Again, this is Nihar Desai from the Yale School of Medicine for the Medscape in Discussion Cardiorenal Metabolic Syndrome podcast.
Thanks for listening to Medscape's In Discussion Cardiorenal Metabolic Syndrome podcast series with our host, Dr. Nihar Desai. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on cardiorenal metabolic syndrome.